Hello, my name is Josephine Achampong. Welcome to my DNP project presentation titled Telehealth and Opioid Use Among Adults with Chronic Back Pain. I was assisted in this project by Dr. Amanda Flynn, my project chair, Dr. Messi Moto, my community mentor, and Dr. Henry Achampong, my physician advisor. According to the International Association of the Study of Pain, pain is an unpleasant sensation that varies from patient to patient. The treatment of pain is multifactorial and it includes pharmacological, psychological, physical, behavioral interventions. The emerging trend is a non-pharmacological approach to management of pain which provide optimum benefits to patients without causing side effects. A patient's ultimate desire is to remain pain-free and attain the optimum level of function as quickly as possible. Pain management can be quick in relieving pain, but their immediate and long-term side effects may aggravate patients' problems. The problem is the lack of adherence to appropriate opioid use. Opioids are among the most effective drugs for moderate to severe pain control, especially among cancer patients. However, opioid medications can be highly addictive and can often lead to the misuse and abuse. In the US, there is an opioid misuse epidemic. Opioids are being prescribed broadly by providers, with patients in disguise requesting opioids for non-medical use. One study found that 17% of adults on prescription opioids reported addiction to opioid use. In the same study, 1/3 of the adults using prescription narcotics to relieve physical pain, 13% admitted misuse, and 64% reported abusing prescription opioids. In addition, opioid use-related deaths have significantly risen in the last decade. In 2013, the cost of prescription opioids misuse was around $78 billion. So the problem is very clear. Opiates are being overprescribed, resulting in addiction and massive amounts of spending on pharmaceuticals. Telemonitoring is the art of obtaining remote access to patients. Telemonitoring services were introduced to continue caring for patients after discharge. Therefore, to improve adherence to treatment, telemonitoring can be used as an intervention. The pivotal question which guided this project is, in adults with chronic back pain, how do weekly telemonitoring cause reduced opioid use compared to in-person visits in 30 days? The practice problem is the overprescribing of prescription opioids. In 1986, the WHO advocated for better treatment of pain. In response to the global demand for better pain management, the Joint Commission introduced specific mandates to promote more effective pain treatments. In 2001, pain was classified as a fifth vital sign, which required documentation using rating scale of 0 to 10, modeled after the WHO analgesia ladder. Providers were mandated to address patients' pain issues adequately. Furthermore, lawmakers loosened restrictions to prescribing opioids, which led to the overprescribing and misuse of opioids. The nation's data survey indicated that almost 92 million adults used prescription opioids in 2015. A total of 259 million prescriptions were written in 2012, and it was estimated 2.1 million individuals who had opioid use disorder was caused by opioid prescriptions in the US. About 60% of opioid-related deaths were due to prescription opioids prescribed under medical board guidance. In 2016, over 17,000 people died from opioid misuse. The Scholarly Project aimed to compare adherence among individuals on opioid medication with telemonitoring to those without telemonitoring. Understanding the role of telemonitoring in reducing opioid use may contribute to the mitigation of opioid misuse and abuse. The researcher hypothesized that telemonitored patients would have better adherence to prescribed opioid medication than individuals without telemonitoring. This inquiry was a practice improvement project aimed to improve patients' adherence to appropriate use of opioid medication and prevent abuse through the use of telemonitoring goals. Telehealth through telemonitoring has been put into practice in various medical institutions to improve patients' health outcomes. Previous research showed that patients with musculoskeletal pain recovered faster with telemonitoring follow-up calls were added to an intervention compared to those receiving usual care. Hence, telemonitoring services may reduce the risk of prescription abuse and increase compliance with treatment goals. Additionally, nursing plays a fundamental role in the implementation of treatment guidelines in clinical practice. Advanced practice nurses are at the front lines in the terms of delivering healthcare services to inpatient, outpatients, in the community. Thus, when it comes to the opioid misuse epidemic, the nursing profession is actively involved in designing preventative-based interventions to reduce opioid misuse rates. A literature search was performed using the academic databases. The primary search concentrated on full text, peer-reviewed, original research dealing with with adults population written in English and published within the last 10 years. The initial search of databases using the keywords telehealth, telephone, opioid use, pain, chronic pain, and adults yielded 308 articles from Sinho and PubMed. After record screening of the journals, 50 articles were assessed for eligibility. Exclusion and inclusion criteria processed 17 articles that were appropriate for the literature review. The articles fell into 4 themes: the scope of telehealth, telehealth and opioid use disorder, telehealth and adherence, and telehealth and self-care management. The literature review indicated that opioid use disorder is prevalent, especially in patients who had received opiates as a treatment for an extended period of time. The required reduction to avoid overdose or dependence was primarily treated with methadone and buprenorphine as the primary intervention in most studies. Adherence to treatment was found to be critical in intervention outcomes, and patients were required to either show compliance with the medication prescribed or to engage in self-care therapy or therapy of pain reduction. The studies found that telehealth was effective and critical in promoting adherence to treatment in individuals with opioid use disorder and a history of opioid overdose. Also, telehealth helped patients with chronic pain to comply with therapy and self-care, which led to the reduction of pain. The literature results show that telehealth services are effective in promoting treatment adherence. The results also show that telehealth is vital in the management of pain for patients with chronic pain. Most of the studies used randomized controlled trials, which represent the highest level of evidence, and use validated survey instruments. Studies also use diverse large populations, and all the literature reviewed is from the last 7 years. As far as weakness, some of the studies had small populations or depended on self-reporting tools, which can introduce bias. The gap that my study feels is the focus on chronic back pain and telemonitoring intervention instead of the other kinds of interventions. The project was guided by Orm self-care deficit theory. The theory integrates elements of nursing system, self-care, and self-care deficit. The theory aids in developing an understanding of how patients can easily recover by maintaining some independence and control over their self-care. Methods in design included quantitative experimental design, retrospective chart review, and pre and post, and participants assigned randomly to intervention and control group. The study used the convenient sampling method. This study was conducted at a pain clinic in the eastern region of the United States. The population of interest include adults 18 years and older, male and female of every race and ethnicity who had a diagnosis of chronic back pain receiving opioids. The study participants were recruited during in-person visits. The recruitment process was in 2 phases. First, the EMR of the patients attending the clinic on the recruitment day was assessed to identify patients that met the inclusion criteria. Thereafter, the selected patients were met in clinic and informed about the study's aims and objectives, their involvement and potential benefits of the study, and the no-risk status of the study. The consent of their participation was sought via recruitment flyer, and those that gave consent were recruited. The inclusion criteria for participating approach in the project were as follows: adults 18 years and older, able to understand and converse in English comfortably, taking opiates for chronic back pain, diagnosis of chronic pain, have been approved by the doctor that they may benefit from physical therapy, and also had access to a telephone. The exclusion criteria include patients scheduled for surgery in less than 4 weeks, patients with a history of psychiatric or diagnosis of substance abuse, and patients on follow-up care reported no pain. To determine the sample size, we use the G-Power software. Using the G-Power estimate, the calculated required sample was 114. This researcher accounted for an attrition rate lost to follow-up of 10%. Hence, the minimum sample size was 125. For this study, the researcher recruited 136 study participants. The population of interest include adults 18 years or older, male and female of every race and ethnicity who had a diagnosis of chronic back pain receiving opioids. There were more females than males, and most participants were between the age of 40 to 59 years old. And here is the visual representation of the demographic data. Participants were randomly assigned to treatment and control groups. Participants in the intervention group had telemonitoring calls within the 72 hours after their index clinic visit, and the researcher called them weekly for 4 weeks. During each weekly telephone call, the researcher reminded the patients about guided home exercise therapy. The control group did not receive any telemonitoring calls. The retrospective chart review of the EMR was employed to collect pre and post data. The data collection tools the research used in the study include the CDC opioid conversion chart in MMEs, point of care urine drug screen, item 34 functional status questionnaire, and the numeric pain rating scale. This researcher obtained IRB approval, informed consent, and followed all the HIPAA guidelines. The data was analyzed using the IBM SPSS software and the Microsoft Excel 2016 version. The researcher expected that most of the intervention, that the post-intervention opioid dose in MME would be non-normal data, and the range would be used to describe the data. However, since the interest of the study was the reduction or non-reduction of opioid dose from the baseline, using population proportions was a better measure of data reporting. Therefore, the Z-test was used to determine the difference in the proportions of those who had telemonitoring and those who had usual care. The 2x2 tabulation of those who had received telemonitoring calls and those who received usual care produced a cell less than 5. The Fisher exact test, which is more sensitive for small cell counts, was selected to compare the post-intervention presence of prescribed medication and its metabolites between participants who received telemonitoring calls and those who received usual care. This data shows the number of participants weekly that withdrew from the intervention or unavailable to answer telephone calls. There was a statistically significant difference in the post-intervention opioid dose in MMEs among those who had telemonitoring calls compared to those without telemonitoring calls. There was no significant difference in the secondary outcome measures, post-intervention pain score, functional status, and point of care urine drug screen. Among the study participants that received telemonitoring call, 72% had reduced opioid dose and 27.8% in the control group. The Z-test p-value for opioid dose in MMEs was 0.022, which is less than the significant level of 0.05. Therefore, the now was rejected. There was sufficient information to suggest a reduction in opioid dose in MME using telemonitoring calls. Among the study population, the change in pain scores were either reduced or non-reduced. A total of 60 participants had reduced pain score, and 76 participants did not have reduced pain score. Among the study participants that had telemonitoring calls, 53% had reduced pain score, and those who do not receive telemonitoring calls, 47% had reduced pain. The Z-test p-value for pain was 0.245, which is greater than the significant level of 0.05. Therefore, we failed to reject the now. There was insufficient information to suggest a reduction in pain using telemonitoring. Among the study participants that had telemonitoring calls, 10% had improved functional status, and 89.7% of participants did not have improved functional status. The Z-test p-value for functional status was 0.6, which is greater than the significant level of 0.05. There was not sufficient information to suggest an improvement of functional status using telemonitoring calls. Among the study participants that had telemonitoring calls, 51 of those who received telemonitoring calls had the presence of prescribed medication and its metabolites. Among those who did not receive telemonitoring calls, 49% had the presence of prescribed medication and its metabolites. The Fisher's exact test reported a p-value of 0.119. Therefore, we failed to reject the now based on our p-value. There was no statistically significant difference of post-intervention presence of prescribed medication and its metabolites between participants receiving telemonitoring calls and those who did not receive telemonitoring calls. The Practice Improvement Project showed a reduction in opioid dose among those who had telemonitoring calls. Comparatively, in earlier studies, telemonitoring calls was associated with improved adherence and reduced opioid dose. The study was guided by the theory of self-care deficit, which was and the goal was to promote self-care of patients in the expectation to improve adherence to therapeutic goals and ultimately reduce opioid doses. The goal of achieving the self-care was achieved because patients who participated in telemonitoring engaged in self-care management, evidenced by the guided home exercises they had in the absence of supervised direct supervision. Reduction in opioid misuse improves self-care efficacy and enhances better quality of life. This mitigates the likelihood of developing opioid use disorder from prolonged use of opioids. Patients who had participated in telemonitoring achieved greater level of self-care. This study used a pre and post design to assess a telemonitoring-based intervention. There was a reduction in opioid dose in MMEs despite the small sample size that was not powered enough. The study was able to achieve statistical significance. The researcher was not blinded. The other modalities of pain management may have been impacted the reduction in opioid dose, for example, steroid injections. In this study, the inclusion and exclusion criteria did not fully address the confounding factors like comorbidities and treatment modalities that might have impacted the management of pain and the use of opioids. The study did not account for subjective factors that play a role in the use of opioids, such as depression, anxiety, and the patient's own personal or subjective use of opioids. As for the small sample size that was not powered enough was a limitation, as well as the self-reporting tools that we used. This practice improvement project proves that providers should adopt telecare for continued care. Healthcare providers must continue to implement clinical guidelines that are effective in minimizing the use and misuse of opioids. Telemonitoring patients at home should be routine care when they use opioids for chronic back pain. The results of this study has potential implication to healthcare policy. The possibility exists that healthcare policies that limit the overuse of opioids in clinical practice may reduce the incidence of opioid use disorder and help in the exterminating of opioid crisis. New policies may require guidelines that emphasize multimodal approaches to chronic back pain, such as the utilization of telemonitoring calls to remind patients to perform guided home exercises. The policy may emphasize on the use of non-opioid medication as the first-line therapy. Additionally, to improve patient outcomes and practice guidelines, there must be a change to the current policy in the management of chronic pain, allowing pain as the fifth vital sign, which might improve the prescribing habits of physicians. Although this study used a pre and post experimental design to assess the difference in care outcomes among those who were exposed to telemonitoring compared to those who were not exposed to telemonitoring, future studies should employ a randomized experimental design. A randomized experimental design will control for the socio-demographics characteristics that might confound the results of the study. Additionally, future studies will build on the limitations of this current study and obtain relevant demographic characteristics such as educational attainment, income, category, and race or ethnicity. As for the DNP impact, this scholarly project shows that the importance of the nurses' impact on promoting evidence-based research and guiding clinical practice. Also, nurses can be involved in guiding healthcare policies and addressing the opioid epidemic. This study shows that a multimodal pain approach of reminding patients through telemonitoring calls to perform guided home exercise as an adjunct therapy was associated with reduced opioid medication. Guided home exercise therapies may serve as an adjunct to pain control management protocols. I would like to thank Dr. Flynn, Dr. Davis, Dr. Ken, Dr. Wonderlich, Dr. Snell, and Dr. Powers for all the support throughout this project. And I'll be able to take questions at this point. And these are my references. And thank you for listening.